everyone. Thank you for taking the time to watch our recorded lecture. This week, Bennett, Megan, and I will be covering Chapter 6, Compliance, Motivation, and Health Behaviors of the Learner. So we'll briefly go over an outline of what will be discussed. First, we'll talk about compliance, adherence, and motivation. Then we'll be discussing some motivational strategies that you guys can use. Third, we're going to be talking about health behavior theories and models. Lastly, we'll go over the roles of healthcare professionals in education, as well as some evidence-based practice. Now I'm going to go over some objectives for this lecture. First is to distinguish the difference between compliance, adherence, and motivation. Then we're going to identify facilitating and blocking motivational behaviors. Third, assess learner motivational levels and identify motivational strategies. Fourth, grasp the concepts of behavior health models, their similarities and differences. And lastly, identify the roles occupied by healthcare professionals as educators. So why is this important? Do you guys ever feel a lack of motivation to do anything? Whether that be assignments, discussion posts, or even group work, or even day-to-day activities like doing laundry, working out, or cleaning the house? I know I do sometimes. If we're feeling this way, then our future patients may feel this way too. So as future OTs, when we work with patients, we are in the role of an educator. We need to understand which factors promote or hinder the learning and application of knowledge, as well as what drives our patients to learn. Knowledge alone does not guarantee that patients will engage in health-promoting behaviors or that the desired outcomes will be achieved. In order to help our future patients achieve their prescribed goals, we must understand the compliance, adherence, and motivation of our patients. So what do I mean when I say compliance, adherence, and motivation? We'll first be discussing compliance and adherence. The terms compliance and adherence have been used interchangeably in the literature to refer to a patient's effort to follow healthcare advice. However, these terms imply different views about healthcare provider and patient relationship. Compliance is defined as the extent to which the patient's behavior coincides with the clinical advice. This has an authoritative undertone. It implies that the healthcare provider or educator is viewed as the authority and the patient or learner is in a submissive role. Adherence, on the other hand, is the extent to which a person's behavior corresponds with agreed recommendations from a healthcare provider. It addresses the need for patients to be involved in the treatment decisions, and it is more patient-centered compared to compliance. So literature has shifted from compliance to adherence, supporting a more inclusive and active patient role. The term adherence is considered more patient-centered than compliance because it supports patient autonomy and the right to choose whether to follow the treatment recommendations. So as OTs, we want to be aware of the adherence level of our patients and help them achieve their goals. So now we'll discuss a little bit about what non-compliance is. Non-compliance is the resistance of an individual to follow a treatment plan. This results in a blaming behavior when clients' goals are not achieved. So some contributing factors to this non-compliance is clients' issues, so their knowledge or motivation, treatment factors such as side effects, disease issues, lifestyle issues such as transportation to sessions, socio-demographic such as social and economic status, and lastly, psychosocial variables such as depression and fear. So as OTs, it's important to figure out why patients are not following our treatment plans. We should be collaborating with the patients to set reasonable and realistic goals that the patient wants to prioritize. Better health outcomes are achieved through patient compliance. We can help improve the compliance of our patients by effectively informing and educating our patients about treatment plans. However, non-compliance is not always a bad thing. Non-compliant behavior may be desirable and could be viewed as a necessary defense response to a stressful situation. So for example, non-compliance may indicate anxiety about the lack of insurance coverage, job loss, family issues, or other underlying concerns that need to be considered. It is important for OTs to look at the patients holistically and understand the factors of non-compliance. A break from sessions may be beneficial as the patient can return from the break feeling renewed and ready to continue with the treatment plan. So now we're going to be talking about non-adherence. So non-adherence occurs when the patient does not follow treatment recommendations that are mutually agreed on. It can be intentional or unintentional. So here are some factors on the slide. I'm not going to read through all of them, but you guys can take a pause on the video to look at the different factors of non-adherence. So for non-adherence, a patient's non-adherence to medical treatment recommendations can affect their health status. So for example, those with diabetes may have medication noncompliance or non-adherence due to misunderstanding, forgetting, or ignoring doctors' recommendations. As OTs, we can work with the patients to get to the root of noncompliance or non-adherence and help them understand the medications and create interventions and goals for medication management. All right, now we'll be talking about perspectives of compliance in regards to theories and models. So theories and models of compliance can be viewed from various perspectives and are useful in explaining compliance from a multidisciplinary approach. So first we'll go over the biomedical theory. It links compliance with patient characteristics, such as their demographics, severity of disease, and complexity of treatment plans. And then the rational belief theory. Clients make decisions to comply or not comply. It's based on cost of benefit logic, and they are weighing the benefits of treatment and risk of the disease. Next is the self-regulatory system. Clients are seen as problem solvers in this. Regulation of behavior is based on perception of illness, cognitive skills, past experiences that affect their ability to plan and cope with illness. Now we're going to the behavioral social learning theory. It focuses on external factors that influence patients' adherence, such as rewards, cues, contracts, and social support. Lastly, communication models. It explains compliance based on communication between the client and healthcare professional. So that is feedback loop of sending, receiving, comprehending, retaining, and accepting information. So it's important to note that these models and theories alone cannot explain the complexities of compliance. A multivariate approach should be utilized to explain compliance. So as mentioned before, compliance has an authoritative undertone. The authoritative aspect of compliance implies that the educator attempts to control to some degree decision-making on the part of the learner. So one way to view the issue of control in learning is through the concept of locus of control. So locus of control refers to the individual's sense of responsibility for their own behavior and the extent to which motivation to act originates from either internal or external forces. So internal would be within self, self-directed behavior. External is influenced by others or outside forces. There's also health locus of control. So that is locus of control related to health behaviors. Individuals' belief is dependent on internal and external factors. So for internals, they believe that they can control their own destiny. Externals, they believe that fate or some other powerful outside source determines life's course. So again, internals' health behavior is self-directed. They believe they control their own destiny. So for example, they might say something along the lines of, oh, although there's a history of osteoporosis in my family, I will have necessary screenings, have the appropriate diet, and do exercises to prevent this problem. External, on the other hand, view others as more powerful and influence health outcomes and believe that fate or some other powerful outside force determines life's course. So for example, externals might say, oh, diabetes run in my family and it will catch up to me, but they wouldn't really do anything about it. So there are 4 dimensions to the concept of health locus control. First one is internal. Again, that's power originating from within, and it's related to personal abilities. There's chance external, which is fate is a powerful outside influence. Others external, so others such as family, friends, and associates are powerful influences. And then doctors external, which refers to doctors having the power to control outcomes. So it's important for OTs to understand the patient's health locus of control in terms of compliance during the evaluation and assessment process, as it will help OTs better create interventions and goals that fit the client's needs. Now we're going to be discussing motivation. Motivation is defined as a movement in the direction of meeting a need or toward reaching a goal, and as a willingness of the learner to embrace learning. So for Maslow's hierarchy of needs, motivation may be based on the needs of the individual. As OTs, our role is to facilitate motivation in our patient by designing attainable goals that address the patient's current needs. So now we'll be looking at motivational factors. Motivational factors can serve as creating incentives and decreasing obstacles to motivation. Motivational incentives are factors that influence motivation toward a desired goal and need to be considered in the context of the individual. What may be motivational incentive for one patient may be an obstacle for another. So this could be seen in our cohort. So certain students are motivated to work with a pediatric population because they've had a rewarding experience with working with kids, whereas other students are motivationally blocked to work with children because their experience with the pediatric populations was under rewarding. So let's take a look into facilitating or blocking motivational factors. So facilitating or blocking factors that shape motivation to learn can be classified into 3 categories. That's personal attributes, environmental influences, and the learner relationship systems. So personal attributes of the learner consist of their age, gender, developmental stage, psychological components, and then everything else there. Each of these can shape an individual's motivation to learn. Environmental influences such as physical characteristics of the learning environment, accessibility and availability of human and material resources, and different types of behavioral rewards can influence the motivational level of the individual. So, for example, loud noises, interruptions, and lack of privacy can interfere with the capacity to concentrate and learn. So, OTs can create pleasant, comfortable, and adaptable individualized surroundings to support a state of readiness to learn. Lastly, relationship systems such as support systems, teacher-learning interaction, cultural identity, work, school, and community roles interact to address the motivation of the learner. Individuals are viewed in the context of their family, community, and cultural systems that have effects on the choices that the individuals make, including healthcare seeking, healthcare decision making. So significant others may have a great influence on health outcomes. Patients may be more likely to make a positive health behavior change when their partner was supportive and also made the health behavior changes as well. So as OTs, we can incorporate significant others and support systems into the treatment plan to facilitate or motivate our patients. So now we'll be talking about motivational axioms. Axioms are premises on which an understanding of a phenomenon is based. So motivational axioms are rules that set the stage for motivation. So there are 5 motivational axioms. So the first one is the state of optimum anxiety. So learning occurs best when a state of moderate anxiety exists. Perception, concentration, abstract thinking, information processing are enhanced. Learners at high levels of anxiety become increasingly self-absorbed, and the ability to perceive the environment, concentrate, and learn is reduced. Those with low levels of anxiety are not very driven to act. Therefore, a moderate state of anxiety can be comfortably managed and is known to be the most effective in promoting learning. So for example, a patient who has been recently diagnosed with breast cancer and who has high levels of anxiety will not be able to retain a lot of information on the treatment options. As OTs, we can assist the patient in reducing anxiety through techniques such as guided imagery, use of humor, words of reassurance, or relaxation tapes. By reducing the patient's anxiety to an optimal level, they have a higher level of information retention. Now we'll be going over learner readiness. So that is the desire to move toward a goal and readiness to learn. Desire cannot be imposed on learners. However, OTs can help promote desire to achieve a goal by introducing incentives. Incentives vary depending on the learner. Incentives are reinforcers and rewards that can be tangible or intangible, external or internal. As OTs, we are acting as facilitators of learning and can offer positive encouragement that can shape the patient's desire to achieve a goal. We can increase the patient's motivation to learn by ensuring that learning is stimulating, the information is relevant and accessible, and the environment is conducive of learning. Now we're going over realistic goals. So goals that are realistic or within a patient's grasp will likely be something they will want to work towards. In contrast, goals that are significantly beyond a patient's reach are frustrating and counterproductive. As OTs, we can collaborate with our patients to set realistic goals. Now we'll be going over learner satisfaction and success. Learners are motivated by success. Success is self-satisfying and feeds a learner's self-esteem. When a learner feels good about a step-to-step accomplishment, motivation is increased. Focusing on success as a means of positive reinforcement promotes learner satisfaction and instills a sense of accomplishment. As OTs, we can utilize the just right challenge to set our patients up for success and increase their motivation to achieve their goals. So uncertainty is a common experience in the healthcare field. Patients and health professionals are often asked to make decisions about the treatment and care options whose outcomes are unclear. An individual's response to this type of uncertainty may vary depending on the individual's characteristics. So uncertainty about treatment options can motivate patients to seek more information and alternatives. So how do health professionals know when a learner is motivated? On this slide are comprehensive parameters for motivational assessment of the learner that include cognitive, affective, psychological, and environmental variables, and the educator-learner relationship systems. I'll give you a minute or two to read through the slide. Please feel free to pause the video and read through each variable. All right, so motivation can be assessed through both subjective and objective means. Subjective measures include self-report measures or interviews with the patient. Objective means include observations of the patient. So as OTs, we can assess motivation by asking our patient questions during the evaluation process. An example of a response from patients may be, I want to be able to take care of myself. This statement shows that a desire of the patient to improve their health. Nonverbal cues can also indicate motivation. So for example, you observe a patient reading brochures about healthy diets in the waiting room. This shows that they are interested and have a desire to have a healthier diet. So after we assess motivation of our patients, we're going to go over motivational strategies. So how do we as OTs motivate an unmotivated patient? Or how do we help a motivated patient remain motivated? As mentioned earlier in the lecture, incentives to motivation can be intrinsically or extrinsically generated. Understanding how to foster motivation is essential as we solely cannot rely on intrinsic motivation to promote learning. So these are a few motivational strategies on the slide here. We'll be going over each category in depth in the following slides. So autonomy and competence are intrinsic motivators that can be enhanced by selecting teaching strategies. So one educational strategy to promote motivation is concept mapping. Concept mapping enables the learner to integrate previous learning with newly acquired knowledge through diagrammatic mapping. As a motivational technique, concept mapping facilitates the acquisition of new complex knowledge through visual links that acknowledge previous learning. It promotes interest and value on the behalf of the learner. So concept mapping is a little bit similar to creating a study guide when studying for tests. Some people like to create charts, others like to create color-coded notes. OTs can work with patients to create concept maps of their goals. This will help patients connect the goals to what they already know and visualize the steps needed to achieve the goals. We will be doing an activity during live lecture about concept mapping. So make sure you understand the concepts of that. So here's an example of a concept mapping that I found online. Feel free to pause the video and look at this further. So motivational strategies that can be used by health professionals typically are extrinsically generated using specific incentives. So as OTs, we can ask ourselves, which specific behavior, under which circumstances, in what time frame may be desired by this patient? So to effectively utilize motivational strategies, we begin with the assessment of motivation that I showed you guys in the previous slides. In our patients that we talked about, again, a couple slides ago, we also need to take into consideration Maslow's hierarchy of needs, as certain needs may be needed to be addressed before the patient can be motivated to strive towards a goal. So now we'll be talking about ARCS. It refers to attention, relevance, confidence, and satisfaction. It's a model that focuses on creating and maintaining motivational strategies that can be used for designing instruction. This model emphasizes strategies that an OT can apply to affect changes in the learner by creating and motivating learning environments. So for attention, it introduces opposing positions, case studies, and variable instruction presentations. Relevance capitalizes on the learner's experience, usefulness, needs, and personal choices. Confidence deals with learning requirements, level of difficulty, expectations, attributions, and sense of accomplishment. Satisfaction is a timely use of new skills and use of reward, praise, and self-evaluation. All right, so the next motivational strategy is motivational interviewing. It is useful to health professionals as they can employ with learners. It is a client-centered directive counseling method in which clients' intrinsic motivation to change is enhanced by exploring and resolving their ambivalence towards behavior change. The purpose of motivational interviewing is to strengthen the motivation of an individual to change. It is a useful collaborative communication technique that encourages patients to talk themselves into changing. Motivational interviewing supports client self-esteem and self-efficacy by emphasizing clients' own reasons for values of change. There are two phases of motivational interviewing that help clients feel empowered. In the first phase, health professionals help clients enhance their intrinsic motivation for change. In the second phase, the commitment to change is strengthened. OTs can utilize motivational interviewing to create a collaborative relationship where we guide the patients through sessions rather than direct them through the sessions. So by doing so, the patient has more autonomy. We are not seen as an authority figure. To guide patients, we can ask them the following questions. What changes are most important to you? How confident are you in making these changes? And what are the benefits or drawbacks in making these changes? How will your life be different if you carried out these changes? So there are 5 general principles of motivational interviewing, which is READS, which stands for Role, Express, Avoid, Develop, and Support. These principles are techniques that should be utilized throughout the motivational interviewing process. So we'll go through each one. Rolling with resistance is a strategy of acknowledging to the patient that ambivalence is natural. Says OTs, we can roll or go with the flow with resistance from our patients as resistance is expected. Examples of resistance include blaming, excusing, minimizing, arguing, challenging, interrupting, and ignoring. When a client displays resistance, OTs can actively involve the patient in the process of problem solving and attempt to explore the reasons behind the resistance. Next is expressing empathy. So it communicates to the patients that they are understood and that they are accepted as they are and where they are in their process. This helps facilitate change. So as OTs, we should refrain from judging, criticizing, and blaming the client. Instead, we should establish rapport by utilizing active listening skills throughout the interview. Next is avoiding arguments. So decrease instances of confrontation, which usually makes the patient feel defensive and could lead to an increased resistance and decreased motivation. So OTs can utilize client-centered strategies to help patients self-identify important issues and problem areas. Next is developing discrepancy. It involves helping patients understand how their current behavior is inconsistent with their personal goals. This realization acts as a source of motivation for change by the patient. The goal is for patients to identify why the change is necessary after they recognize the inconsistencies between their behaviors and their goals. Lastly, supporting self-efficacy involves building clients' confidence that change is possible. To accomplish this, OTs provide support and recognition for any small steps that the patient has made toward their goal. OTs can also help by setting attainable goals and demonstrating belief in the patient's ability to succeed. All right, so in addition to the motivational interviewing approach, the motivational interviewing approach includes specific strategies that help health professionals to build motivation to change throughout the treatment process. So this is called OARS. Again, these are specific strategies you can use during the motivational interviewing process. So first is open-ended questions. It facilitates discussion between health professionals and patients. By utilizing open-ended questions, OTs can encourage patients to do most of the talking and discuss reasons why change is necessary or desirable. OTs should avoid closed-ended questions that result in yes or no answers, as it limits the discussion during the interview process. Next is the affirming the positives. So it involves the health professional making statements that support and encourage the patient, especially in areas where the patient sees only failure. To provide affirmations, OTs compliment the patient's effort, acknowledge small successes, or stating appreciation and understanding. By providing these affirmations, OTs are promoting self-efficacy, they're building rapport, and reinforcing the patient's efforts towards making a change. Next is reflective listening. It involves the health professional restating what the patient has said in a concise manner. So as OTs, we can utilize our active listening skills to convey to the patients that we are listening. It helps facilitate conversation so the patient can recognize and appreciate the need for change. So lastly is summarizing. It links and reinforces the information that has already been discussed through the interview. OTs can summarize even throughout the treatment process to build rapport with clients and to demonstrate that the client's concerns are heard. It emphasizes significant parts of the conversation and reviews the treatment plans and goals with the patient. So on this slide here, there are some examples of questions or statements that you can use in each stage of this strategy for motivational interviewing. All right, so next, Bennett will go over selected models and theories.
Theories explain behavior or events. Models are more descriptive than explanatory and serve as learning devices to help understand key components and relationships. So you may ask, why is learning models and theories important as future occupational therapists? Understanding the principles of these frameworks can either promote adherence to a health regimen or facilitate motivation in the process of describing, explaining, or predicting health behaviors. Whether interacting with individual patients, groups, or members of the community, or trying to design plans and programs to apply in educational and clinical settings, health professionals can use the models and theories summarized in this lecture to help determine what factors are important in describing, explaining, and trying to change health behaviors. The current trend is to employ an interdisciplinary approach and pick and choose among the models or integrate multiple models that best meet the specific needs and characteristics of particular patients, groups, communities, and settings. So, no one best model for particular patients, groups, communities, and settings is available. It's more like we have to determine what's best for our client or population. The first model we are going to look at is the health belief model. This model explains and predicts health behaviors based on clients' personal beliefs about the health problem and the health behavior. It relies on the assumptions that the client is willing to participate and they believe health is very important. Both of these premises need to be present for the model to be relevant in explaining health behavior. This model is grounded on the supposition that it is possible to predict health behavior given three major interacting components, which are individual perceptions, modifying factors, and the likelihood of action. Individual perceptions are the subcomponents of perceived susceptibility or perceived severity of a specific disease. Modifying factors include the demographic variables, socio-psychologic variables, and structural variables. These variables, in conjunction with cues to action, influence the subcomponent of perceived threat of the specific disease. The third interacting component is likelihood of action. This includes the subcomponents of perceived benefits of preventive action minus perceived barriers to preventive action. Now you may think, oh man, Bennett, those are a lot of words. Well, let me give you an example with that. So let's say that someone comes from a family that did not drink at all. But with drinking, we know that there is a higher chance of lung cancer. So because this individual came from a family that did not drink, his family, let's say, did not get any lung diseases or lung cancer. So he has a perceived susceptibility that he will not get lung cancer and he won't worry about it at all. And also, he may not think that it is something serious to be careful of. Therefore, with his family not having any issues with their lungs and his perceived susceptibility, he may not see it as a threat as he continues on with his drinking problem. But if we talk about perceived benefits of preventive action by teaching that client of the dangers of over drinking or what alcohol addiction can do to someone, we can introduce the benefits of stopping drinking. But there's also the issues of what it might take to stop drinking, which will be a perceived barrier to those preventive actions, which might include um, just the difficulties of withdrawing from something that has been addictive to that client. A cue to action is something that can help them overcome that disease, or um, something like mass media or a friend also participating in withdrawing from that threat to their health. So let's say that client has a friend who's also suffering from alcohol addiction, but that friend calls on him to quit together. And so because of that, that cue to action will influence the likelihood of taking recommended preventative health action. The second model we are going to look at is the health promotion model. This model assists in understanding the major determinants of health behaviors as a basis for behavioral counseling to promote healthy lifestyles. It identifies and describes the major components and variables that influence health promoting behaviors. This is distinguishable from the health belief model that we just discussed, as this focus is on health promotion rather than disease prevention. So there are three, three components in this. The first one is individual characteristics and experiences, which consists of two variables: prior related behavior and personal factors. The second is behavior, which includes specific cognitions and affect, which consists of perceived benefits of action, perceived barriers to action, perceived self-efficacy, activity-related affect, interpersonal influences, and situational influences. The third factor is behavioral outcomes, which consist of health-promoting behavior partially mediated by commitment to a plan of action and influenced by immediate competing demands and preferences. There's a comprehensive strategy which includes three core components: a behavior change approach, a strong policy framework that creates a supportive environment, and empowerment of individuals to gain more control over making their own health lifestyle decisions. So let's use an example of, let's call him James. And James wants to lose weight. So he has engaged in a lot of binge eating, which we can call his prior related behavior. And his personal factors could be that his family also ate a lot of food and thus um, became a household environment of overeating, the the standards of calorie consumption. So things that we can see here are perceived benefits of action, which we can teach the client of, let's say, exercising as the intervention. We can teach them how exercise is a great um, intervention, as you can burn calories and through all the other health benefits that exercise can give, um, that can influence the mind and just create a healthier person overall. And activity related affect with exercise, it is something that can um, affect a person in many ways. The perceived self-efficacy can be if James believes that he can do it and that he can change. And so if he had a high self-efficacy, it would push him because he believes that he can exercise and work out and overcome his obesity issue. Perceived barriers to action can be anything that can limit him from exercising. This can be a lack of a gym nearby in the community, or maybe he does not have exercise equipment due to low socioeconomic factors in the household, or maybe the community is not safe to run outside. And then there's a commitment to a plan of action, which is added here, which combines the prior related behavior and the personal factors. That is important in this model because what we can basically talk about in this model is that greater personal commitment to health um, will show more likeliness of that individual for the health behaviors to be maintained and basically support that health promoting behavior. The next model is the self-efficacy theory. This theory is a predictive theory based on a person's expectations relative to a specific course of action and that they believe they can accomplish a specific behavior. So some factors are performance accomplishments as evidenced in self-mastery of similarly expected behaviors, vicarious experiences such as observing successful expected behavior through the modeling of others, verbal persuasion by others who present realistic beliefs that the individual is capable of the expected behavior, emotional arousal resulting from self-judgment of physiological states of distress. And basically, the higher the self-efficacy is, the more they believe they are capable of accomplishing a task. So now we are going to look at a SpongeBob clip that can demonstrate the self-efficacy theory in action.
I'll just have to turn you into men.
You can do that? How?
With my mermaid magic.
Shh! Did you hear that, Patrick? She'll use her mermaid magic to turn us into men! Hooray! We're gonna be men! We're gonna be men! We're gonna be men!
Good, now let's get started. Close your eyes.
Are we men yet?
Not yet. Spin around 3 times.
I think it's working.
Good, now keep your eyes shut. With my mermaid's magic and my one tail fin, I command the 2 of you to turn into men. Open your eyes.
Huh. I don't feel any... Oh my gosh, Patrick! You have a mustache!
So do you!
Oh. Oh.
So now that you're men, can you make it to Shell City? Guys,
Huh?
I said now that you're men, can you make it to Shell City?
Heck yeah!
Are men afraid of anything?
Heck no!
And why?
Because we're invincible!
I never said that!
Yeah. Patrick,
Yeah, buddy?
why did we jump over the edge instead of taking the stairs?
Because... well...
So from that SpongeBob clip, you can see that SpongeBob and Patrick had a higher self-efficacy to make their way to Shell City because they believed that they were men. That high self-efficacy made them feel that they could believe that they were brave enough to basically surpass the journey that they were about to overcome. The next theory that we're going to look at is the protection motivation theory. This explains behavioral change regarding terms of threat and coping appraisal. It helps explain participation in unhealthy behaviors, and it gives rise to protective motivation, followed by intent, then ultimately leading to action. So it explains behavioral change in terms of threat and for understanding how it's beneficial in why individuals participate in behaviors that are unhealthy. So there is a cognitive assessment whether there's a threat or not. And it has a use in behavioral intervention because it can see like why people switch to negative coping mechanisms instead of positive ones. So what we can do in behavioral interventions is to change those negative coping mechanisms into positive ones, such as exercise, which can boost a person's mood and a good coping mechanism in general. So the basics of it is to find the threat and to change that threat to a good coping mechanism to support their health. The next model that we're going to look at is the stages of change model, which is also known as the trans-theoretical stages of change model. So of these, it's more like a cycle with these stages. The first stage is pre-contemplation. The second stage is contemplation. The third stage is preparation. The fourth stage is action. The fifth stage is maintenance. And the sixth stage, termination, rarely happens, but usually it's more of a cycle of repeat back to pre-contemplation if there is any issue with the maintenance. So the first stage, pre-contemplation, individuals have no current intention of changing, and strategies here involve simple observations, confrontation, or consciousness raising. The second stage is contemplation, which individuals accept or realize that they have a problem and begin to think seriously about changing it. Strategies involve increased consciousness raising. In the preparation stage, individuals are planning to act within the time frame of 1 month. Strategies include a firm and detailed plan for action. In the action stage, there's overt or visible modification of behavior. This is the busiest stage, and strategies include commitment to the change, self-reward, countering, creating a friendly environment, and supportive relationships. The fifth stage is maintenance, which is a difficult stage to achieve and may last 6 months to a lifetime. There are common challenges to this stage, including overconfidence, daily temptation, and relapse self-blame. The strategies in this stage are the same as those for the action stage. So this theory was developed around addictive and problem behaviors. It is useful for staging the client's intentions and behaviors for change, and to determine if those strategies will enable completion of the specific change. So with an example of drug use, let's say an individual is wanting to get help for their drug addiction. If they are only thinking about it, but have no actual thought about changing their behaviors at all, it is probably at a pre-contemplation stage. But if they realize that they do have a problem and they are seriously thinking about changing it, they would be at the contemplation stage. For someone who is starting to look for resources and maybe looking for any support groups that are available, they would be in the preparation stage as they're getting ready to take action and start getting help. Participation in a support group for drug addiction would be the action stage, and maintenance is the same strategies as the action stage here. The next theory is the theory of reasoned action and a theory of planned behavior. The behavior can be predicted by examining one's individual attitudes about the behavior and the beliefs about how others might respond to the behavior. It's based on beliefs that are influenced by emotions and mood. Specific behavior is determined by beliefs, attitude toward the behavior, and intention, and the motivation to comply with influential persons, subjective norm, and intention. Attitudes refer to a person's positive or negative thoughts concerning behavior. Thoughts influence the attitude. Our beliefs of consequences of carrying out a specific action, and second, our evaluation of those consequences, such as are they positive or negative. For example, when using this theory to predict how a client might respond to a weight reduction plan, it would be vital not only to consider the client's beliefs about food and exercise, but also to examine what the client might think about how the people around him would view his attempt to lose weight. Next is the theory of planned behavior. This theory is actually like adding a concept of perceived behavior control to the theory of reasoned action model. In ways, there's a lot of things similar, but the elaboration is the perceived behavior control, and it refers to a degree of personal control of behavior in question, such as how well we believe we can perform the behavior. If we think we have a strong internal locus of control to our behavior, or the ability to overcome barriers to that behavior, then it will be more likely to perform that behavior than if we were influenced by something else. Intention and perceived behavioral control are both equal influential predictors of behavior. So let's say back to the exercise of working out. If we can see that working out can really help us maybe lose weight, for example, and reduce obesity, it can overcome the intention to work out and actually become a behavior to work out more instead of only just becoming an intention that would lead up to behavior. So this would skip the intention here because in a way they are both equal predictors of behavior. Next is the therapeutic alliance model. Learning partnership between collaboration and negotiation with the consumer become key. The caregiver and the care receiver are viewed as having equal power. So in this picture, we can see that the therapeutic alliance has equal power in the patient and to the provider as well. Motivational interviewing may be combined with the therapeutic alliance model, and successful motivational interviewing takes place in an atmosphere in which the patient feels understood and respected and is collaborative in nature, with the highest priority placed on the patient's autonomy and the freedom of choice. The next model here is social ecological models. It gives direct focus to the societal context or environment of individuals within which their health behaviors occur. Most would agree that individuals who may be motivated to change their behavior will find that it is much more difficult if their social situation and environment work against health behavior change. A positive social environment, however, encourages such changes and may even motivate individuals who initially had no interest in changing their health behavior to break bad habits or improve their health. So I know I keep going back to the example of exercising, but let's say Jim, who works at the office, is very sedentary in his lifestyle. And Jim has coworkers who were also sedentary, but they began to work out more often and invite Jim over to the gym that they go to. So with that, it would be a positive social environment that would support the habit and behavior of exercising, which will help improve the health of Jim and break the bad habits of a sedentary lifestyle. So there are 5 levels of influence here. There are intrapersonal or individual factors, which include individual characteristics such as age, biological and personal history, education, income, health information, and knowledge, attitudes, and beliefs, religion, and a host of other psychological and social factors that are pertinent to the particular health behavioral goal. Interpersonal and relationship factors, which are personal relationships that are likely to exert an influence, which can be positive or negative, on health behavior, such as friends, family, and close group affiliations, which in my example before would have been Jim's coworkers who invited him to work out more. The third level of influence is organization and institutional factors, which can include religious organizations, workplace organizations, and other organizations and institutions that may have a bearing on health behavior. Fourth is community factors, which include community norms, neighborhoods, safety, and relationships among institutions in the community. And the fifth is societal or public factors, which are public policies and laws regarding health behaviors, public recreation facilities, and legislative and government support for health policy and facilities. So next, I'm going to pass it on to Megan to explain the models for health education.
Research focusing on the models for health education found that interventions using these specific healthcare models did result in behavioral change. The selection of models for education use are based on the following. 1, the similarities and dissimilarities in the available models. 2, the health professionals' agreement with a model's conceptualizations. And 3, the functional utility of the model, which we'll go more into detail within the next few slides. So first we'll go over educator agreement with model conceptualizations. The educator agreement with model conceptualizations is based on the best fit of model or theory depending on what the educator intends to do. The following tables outline the purpose of using the theory or model. First, we have the health behavior model, which focuses on likelihood of action. Next, we have the protection motivation theory, which focuses on attaining positive health outcomes. Next, we have the theory of reason action and the theory of planned behavior. Both focus on attitudes and intentions of the client. Next, we have the self-efficacy theory and the self-determination theory, which both focus on belief in one's own capabilities. Next is the therapeutic alliance model, which focuses on reduction of non-compliance. Then we have the stages of change model, which focuses on staging readiness. And lastly, we have the social ecological model, which focuses on designing health education campaigns. Next, we'll talk about the functional utility of models. The following questions can be asked by the educator in order to determine the functional utility of the model being used. 1, we have who is the target learner? 2, we have what is the focus of the learning? 3, when is the optimal time? And 4, where is the process to be carried out? The following slides outline the similarities and dissimilarities of the models. As we can see, the health behavior model and the health protection model both describe the use of factors or components that influence perceptions, possibly leading to positive health outcomes. However, the health behavior model targets the likelihood of engaging in preventative health behaviors, whereas the revised version targets the likelihood of engaging in health promotion activities. Second, we have the 4 following theories, which is the stages of change model, self-efficacy theory, the theory of reason action, and the theory of planned behavior. All 4 focus on intent. However, the stages of change model does not account for personal experiences or characteristics and differs from the rest in that change is time relevant. Time relevant gives more implications for education, which is why this one may be more essential. So why would we integrate the models for use in education? Integration is essential in order to individualize learning and create the best educational program and setting for clients. So it's important to understand each of the previous elements for integration. So now we'll go over health professionals as educators in health promotion. Health professionals such as occupational therapists occupy multiple roles as educators by combining content from our specific discipline with psychological, sociological, and educational theories. This creates a more integrated and effective approach to promoting healthy behaviors. These roles include facilitator of change, contractor, organizer, and evaluator, which we'll go more into detail within the next few slides. So the first role we occupy is facilitator of change. This is because the ultimate goal of healthcare is to effect change in a patient's routine or behavior to promote their overall health. In this case, teaching can be viewed as a healthcare intervention, which establishes the healthcare professional as a facilitator of change. Specifically, this involves actions such as explaining, analyzing, dividing complex skills, demonstrating, practicing, asking questions, and providing closure. The second role we occupy is a contractor. Educational contracting involves stating mutual goals to be accomplished, devising an agreed upon plan of action, evaluating the plan, and deriving alternatives to that plan. Educational contracting is important as occupational therapists educating clients because it makes the learning individualized or client-centered and establishes a trusting teacher-learner relationship. According to a study by Newman and Brown, the elements essential of an ideal teacher-learner relationship include the following. Both parties have trust and respect. The teacher assumes that the learner can learn and is sensitive to individual needs, and that both parties feel free to learn and make mistakes. Educational contracting, in this sense, can promote these essential elements. The third role we occupy is as an organizer. Organizational tasks that a health promotion educator may participate in include manipulating materials and space, sequential organization of content from simple to complex, or the intentional detailing of important concepts, and determining the priority of subject matter. You wouldn't just throw unorganized and unintentional details to clients expecting them to decipher the information and apply it to their routine. This is why organization is essential for learners to understand and apply learning objectives easily and decreases obstacles to learning. The last role we occupy is as an evaluator. As we may know, evaluations include tests, projects, papers, presentations, etc. Forms of evaluations include self-evaluations, learning evaluations, organization evaluation, and peer evaluation. The evaluative process is not just for the learner, but also for the educator. This process ensures accountability of the educational program. It is important to note that in health education and promotion specifically, the variables being measured include 1, the application of knowledge, and 2, whether this knowledge improves the health of individuals, families, groups, or communities. Moving on to the state of current evidence. There is unfortunately less than adequate research when it comes to implementing intervention in healthcare that specifically address compliance, motivation, and adherence. One article mentioned by the textbook written by the U.S. Department of Health and Human Services identified 4 major goals of health education. 1, to attain high quality, longer lives free of preventable disease, disability, injury, and premature death. 2, achieve health equity, eliminate disparities, and improve the health of all groups. 3, create social and physical environments that promote good health for all. And 4, promote quality of life, healthy development, and healthy behaviors across all life stages. This emphasizes the importance of health professionals to promote desirable health behaviors of the learner. Therefore, evidence on compliance, motivation, and adherence is essential to future practice. Other research articles mentioned by the text highlight the lack of research and specific guidelines for educators in promoting motivation for health behaviors. If you're interested, page 274 of the text details the conclusions of these studies. An article we found, however, by Hink et al., promotes the use of motivational strategies, specifically concept mapping, as an effective educational tool and motivator in health education. The study's title is Student Learning with Concept Mapping of Healthcare Plans in Community-Based Education. The purpose of the study was to test the effectiveness of concept mapping for student learning and their satisfaction with the strategy. The study included a pre- and post-test with 23 student participants in a community-based mental health course. The findings of the study included that concept mapping significantly improves students' ability to see patterns and relationships, and 2, that concept mapping helps students plan and evaluate their learning. Although this article does not specifically measure levels of adherence or motivation, it does act as a stepping stone towards future research of the effectiveness of motivational strategies. During our live lecture, we will review concept mapping and practice using this strategy. So let's review the main concepts of this chapter. 1, we have the definitions of compliance and adherence, as well as non-compliance and non-adherence, and how clients may or may not fall into these categories, as well as what motivation is. Compliance can be defined as patient's behavior that coincides with clinical advice, while adherence can be defined as a person's behavior that corresponds with agreed recommendations from a healthcare provider. So they're much different, and they're used in different settings and in different concepts based on the textbook. Next, we have motivational factors and how they may be facilitated or blocked, how to assess motivation of the learner, and strategies to promote motivation for successful health promotion and education. These motivational factors and how they may be facilitated or blocked include personal attributes, environmental influences, and relationship systems. The motivational strategies, on the other hand, include intrinsic, extrinsic, ARCs, and motivational interviewing. Third is what the behavior health models and theories and whether or not how to apply them to specific learners. So these models include the health belief model, health promotion model, self-efficacy theory, protection motivation theory, stages of change model, theory of reason action, and theory of planned behavior, theory of a therapeutic alliance model, and the social ecological model. And lastly, the roles of healthcare professionals as educators in health promotion. These include facilitator of change, contractor, organizer, and evaluator. Lastly, we have our references used within this lecture. For live lecture, make sure you go over the concept of concept mapping, as well as go over the health behavior models and motivational strategies. We'll be doing a short quiz and practice using them in group discussion. Also remember that there are 2 discussion questions due on Wednesday, as well as there's replies due on Sunday, a quiz due on Friday, and the peer review due on Friday as well.